Welcome to tonight's webinar, Patient-Provider Communication in the Time of COVID-19, Tips for the Front Lines. We're so very glad you're joining us. My name is Sarah Blackstone, and I'm the facilitator for this webinar. Tonight's program is brought to you by the United States Society for Augmented and Alternative Communication, or USAC, the voice of AAC. We want to thank USAC's Education Committee and Disaster Relief Committee and ISAC for making this evening possible. These are difficult times for everyone. We hope you are all staying safe and healthy. The response to tonight's topic is overwhelming. We had close to 175 people register. The webinar is being recorded and will be archived, so it'll be available to all. We encourage you to support and join USAC. And just by the way, one of our membership benefits is early registration for any of the webinars. Also, USAC includes a membership in ISAC, so you become part of the larger international community. Now, we're going to go over some logistics with the next slide, right? So your microphone is muted. We won't hear from you. However, you can ask questions by typing into the question box in the lower right-hand corner of your screen. Questions are going to be answered as time allows in the last segment of the webinar. We're going to maybe group some of your questions together if they're similar, and we do ask that you pose your questions in a general fashion rather than related to a specific individual. Also, questions that we don't have time to respond to during the webinar, we may answer for you by email later on. This webinar is also going to be, we'll be using ASHA CEUs, and if you are interested in receiving ASHA CEUs, just for your information, you need to be on the webinar for the entire time. It's free to USAC members, and there's a $25 charge for non-USAC members. If you go to the website, USAC's website, you will find the participant form and instructions as to how to fill it out and where to send it. You're going to be scanning the form and emailing it by May 12th so that they can be submitted to ASHA. Following the webinar, you'll receive an email with a link to the archive, which also has the form and instructions. So on to the next slide. Now I would like to introduce our speakers, Tami, Altschuler, Rachel Santiago, and Jessica Gormley. All are speech-language pathologists and frontline service providers in hospitals. They are also contributors to the literature and sought-after presenters. All are playing key leadership roles every day on the Patient-Provider Communication Forum's task force and in hospitals. Tami's a clinical specialist in patient-provider communication in the Department of Speech and Language at NYU's Langone Medical Center in New York City. She spearheads the initiatives there throughout her hospital. Today is her day off. Otherwise, she's working 12-hour days, 4 days a week in the ICUs. She also serves on the board of directors of USAC as liaison to ISAC. Rachel is a clinical coordinator of inpatient AAC programs at Boston Children's Hospital. She's initiated programs, hospital initiatives, and in-services, working collaboratively with families, child life, and many service providers to integrate patient-provider communication into daily practice. For your information, she's still at the hospital tonight. And Jessica is Assistant Professor and Program Leader for AAC Implementation at the University of Nebraska's Medical Center Monroe-Meyer Institute. Her dissertation focused on patient-provider communication in healthcare settings. She was back at work at the hospital today to help with a patient who's having communication problems. These women met years ago at the Patient-Provider Communication Forum and have been collaborating ever since, including on a white paper that will make it easier for all of us to access research information. Disclosure, none of our presenters are getting paid for this. They all are obviously have relationships in the field. So let's go on to what you're going to learn about tonight. Tonight's learning objectives are to learn about existing patient-provider communication barriers in hospitals, AAC strategies that optimize patient-provider communication during COVID-19, this pandemic, and finally, emergency preparedness and communication planning strategies to support people who use AAC. So we're going to turn it over to Jessica.
Hi, everyone. I'm going to show you my screen really quickly. Thank you, Sarah, for the kind introduction. And thank you, everyone, for joining us today as we're talking about our discussion about something that seems to be maybe running most of our lives right now, which is this COVID-19 pandemic. So as I said, the COVID-19 pandemic has undoubtedly impacted everyone's lives in some way at this point, including everyone in today's session. Had some stats, these were from yesterday, but these are already out of date today. Over 3 million people have been confirmed to have the virus. And communication difficulties are a common complication from the virus, and we're all at risk for COVID-19 related communication difficulties, which I think that this topic is quite timely, and I'm glad that we have the opportunity to discuss what things might be of importance and to consider as we are preparing for the future. It's really important to recognize that people who already use AAC may be at high risk group for undergoing a hospitalization due to some of their underlying medical conditions that they might have. And that's all going to be really important to consider as we're moving forward as well. So preparing patients and potential patients and providers with resources is going to be key to make sure that communication is an effective and a positive experience for everyone that is involved. COVID's brought a lot of attention to patient-provider communication and communication access worldwide, and we wanted to start and talking about a little bit about what we know from the research base and from our years of experience providing services in the healthcare settings. So what do we know so far? Well, we know that there's a lot of variables that really can impact how effective communication is within hospitals. And here are some variables listed right now. So the medical treatment that a patient undergoes, such as intubation or tracheostomy, makes it difficult for producing speech. Patients might have neurological disorders or sensory challenges that make it difficult to understand or understand what's happening to them in a hospital. So express themselves within the hospital environment, and might have some baseline language challenges as well, or difficulties reading or writing when getting information from their medical chart or from understanding kind of discharge instructions and education materials. It's also really important that we're considering that patients and providers speak different languages. That introduces another layer of complexity to the communication process. We want to make sure that everybody in that interaction is understanding everything that the other is expressing, and vice versa. So we know that these are all some, when we're experiencing some of these communication vulnerabilities, that they might have an impact on the communication success. And there is a lot of these individuals may have increased risk with some not so pleasant outcomes. So we know that when there are communication barriers, research shows that in people with communication disorders, including those who may rely on AAC strategies, may experience increased serious medical events and increased preventable adverse events. And those are things like falls and medication errors and just miscommunications in general. That communication difficulties are actually within some of the top 3 reasons that are cause for medical events, which is really huge to consider down the line. A recent study in 2008 found that people with communication difficulties, adults specifically, are 3 times more likely to experience a preventable adverse event. And when looking at that in numbers, an estimated over 600,000 preventable adverse medical events that cost over $6.8 billion in the United States alone every year. So this has a huge impact on, of course, the hospital experience and hospital safety, but also kind of the bottom line, which is really important to have our administrators and our hospital policymakers understand that this has such an impact on many different levels. When communication difficulties exist, there's also an increased risk of misdiagnosis of psychopathology because providers might not be understanding what's happening with a patient because of a communication of difference. So sometimes that might be confused, which can introduce an inappropriate use of medication and just kind of a really complicated course of the hospitalization. Some other risks that we know from the literature is that people who have communication difficulties or communication disorders may have a poor medication compliance. They are at increased risk of leaving against medical advice, perhaps because of difficulties understanding what providers are saying and providers not communicating information in a way that's accessible to everyone involved. And that we know that there is just time and time again so much out there about just the negative hospital experience in general. So patients who may use AAC or may use some different ways of communicating, they report significant increased feelings of fear and stress, difficulty sleeping, and report that they have a loss of ability to control or participate in their own care. And that we know leads to really poor outcomes and so many different levels to prevent. We want to make sure that everyone's having a positive experience. It's important to remember that that this is all before the pandemic, that there are a lot of risk involved, and when we're talking a little bit later, we're going to be seeing how some of these risks and barriers are even amplified with the presentation of COVID-19. Now, no one is waking up in the morning wanting to perpetuate communication breakdowns. However, these barriers exist to implementing AAC, and it's really important to recognize what sorts of issues exist so we can find solutions that can support both the patients, providers, families who are in this really complex experience. So Tami and Rachel in 2018 did a survey on contacting individuals who are speech language pathologists in the United States who work in acute care settings, and about trying to get a pulse about some of the barriers that they've experienced when they're using AAC in hospitals. And they found that these kind of 5 main reasons are barriers to AAC implementation. Providers and hospitals don't have the resources they need, the knowledge they need, the practices that they need, attitudes maybe, and maybe impede the use of AAC services, and the hospital environment itself is just really challenging to have adequate implementation because of just the fast-paced nature and the time limitations that are imposed on everyone involved. So it's a bit of an uphill battle to begin with. But the good thing is that there's when it does work and patients do have access to an effective communication system, we see a lot of positive things. We see that patients receive less sedation, they transition more quickly to lower levels of care, so they're not staying in acute care hospitals as long. They're able to go transfer to rehab or back home or back to their to a lower level of care. They're also provide increased patient satisfaction scores. They feel better, they feel like they're more in control, and they're an active participant in their care. So that's all that that's what we're hoping for. We're hoping for all of these positive effects. And because the research is showing that when people have access to effective communication systems, that we see these positive outcomes, accrediting bodies like the Joint Commission, which is in the United States, is providing guidelines that hospitals need to provide these supports to patients at all levels of care, on admission, assessment, and during intervention, regardless of disability status, age, communication status. Everyone deserves and it has the right to have this high quality access to communication supports. So before we get into specifically to COVID-19 communication challenges, we just want to kind of show this is the context of what it was before. There's challenges on both sides. So patients are experiencing challenges in acute care. They might have difficulty breathing to sustain speech in their voice. They might have difficulty staying awake and staying alert because of the medications they're on or the procedures they've gone through, and just for trying to recover and feel better. There might have difficulty with positioning and motor access to their systems because of weakness or being kind of tied down with lines and different things. They might be isolated and they have high risk of delirium. And providers also have challenges that they're facing. They have limited time to interact with patients. They have to wear this PPE or this personal protective equipment, which Tami will talk about later. There's a lot of stress and fears right now in the healthcare system about what's happening next. Staffing, do we have supplies? Are we doing, do I have everything that I need? And this hospital culture really plays a huge piece into how effective communication is, and also the access to equipment and kind of the processes throughout the hospital experience. We also have providers who have very different experience levels. We have medical residents who just graduated early, who are now in charge of units and being the attending physician. We have people who might be in different situations with different levels of experiences and resources. And so all of this together, it created a communication crisis to begin with, where we need resources, we need training, we need a prepared workforce to meet the needs of people with communication difficulties. So I'm not going to be the bearer of bad news all the time. The good thing is that we're not focusing on barriers throughout this whole presentation. We're going to try and look at solutions to some of these barriers. And I'm going to hand it over to Tami now, who is on the front lines every day working with people who have COVID-19, and is going to show some of the solutions that she's experienced kind of as her time throughout being a speech language pathologist in New York City, and how she has adapted and met the challenge to find some effective solutions to supporting communication. So I'm good.
Thanks, Jessica. About 6 or 7 weeks ago, the PPC task force, we started talking about the communication difficulties that we anticipate patients and healthcare workers experiencing. And we got together and we created some tools, and we'll discuss some of those resources tonight. As Jessica said and Sarah said, I'm working in the ICUs all day, and New York City is the epicenter. And things may look a little different where you are, but the difficulties may still be the same. And this is evolving, and what we discussed today may look very different in another few weeks. And who knows, we may be back in another few months doing another webinar with new information that comes out. But these are the barriers which we are discussing today, and these are our findings of how to guide communication difficulties and COVID-19. We know that COVID-19 can lead to different levels of respiratory distress, and if you have difficulty breathing, then you have difficulty speaking most likely. There are several levels of respiratory support which impact communication. Shortness of breath. I have actually recovered from COVID-19 and pneumonia, and I experienced shortness of breath myself. I thankfully did not need to be hospitalized or require any respiratory support, but I became short of breath when I was speaking, and I had a hard time. There was one night where I couldn't really speak in full sentences, and so I had to speak in shorter phrases. My vocal volume was lower. I would trail off at the end. And some patients, thankfully I did not experience this, but some patients experience low oxygen in their blood, which can impact their cognition. One way to help with respiratory support is BiPAP, and it's a way to deliver positive airway pressure. And so as you can see in the pictures, there are different masks that can really limit the range of motion that we need to produce speech. And as a result, we can have a really muffled sound from the positive pressure. We can have a hoarse voice. Our voice can fluctuate. When patients need more help and the BiPAP is not enough, they unfortunately need to be intubated. And a breathing tube is inserted from the mouth to the lungs and you need to be placed on a ventilator. You are sedated for the procedure most often, but then you get the sedation for spontaneous breathing trials, and that's to see if you can breathe without the help of the ventilator. I'm seeing some patients who are kept deeply sedated, and so they don't really need any communication supports right now. But then some patients are being weaned off the sedation maybe an hour or two before the tube comes out or before they try these spontaneous breathing trials, and those patients are often awake and alert for this. They're communicating most likely by mouthing words. And I am really horrible at lip reading, and I think most of us actually are. And there's a huge discrepancy with our own confidence in our ability to lip read and how efficient we are. I often ask a nurse or a doctor when they work with a patient at the bedside, and the patient's mouthing words, say, how often do you really feel like you're getting what they're saying? And people give me responses like it's 80% of the time or it's 70% of the time. And then I ask the patient and I often get the answer of, I feel like I'm understood maybe 30 to 20% of the time. And that's really challenging if someone's trying to say that they're in pain or they need the bathroom, or especially if they're making medical decisions. Sometimes this intubation tube stays in for a few days, or you can have a prolonged intubation where it stays in for a few weeks. And when the patient is unable to get off of the ventilator and breathe on their own, they need to have a tracheostomy placed. A tracheostomy is a surgical opening in the neck where a breathing tube is placed. I'm kind of explaining this in plain language because I don't really know who our audience is. So some of us are speech pathologists and some of us are maybe just general public. So when you have a trach, which I'll just call it that for now, you start off on the ventilator. And you cannot speak because the airflow exchange is between the vocal cords. So you're not getting air that goes up through the vocal cords to produce any voice. You might eventually use something called a speaking valve, which allows that airflow to go through the vocal cords. The patient needs to be on trach collar for this and off of the vent. And some speech pathologists who are listening right now might wonder why, because sometimes we do something where we call an inline speaking valve. And right now at my hospital, we're not doing that because in order to do that, we have to break the circuit for the vent. That's considered an aerosolizing procedure, meaning we can create droplets of the virus, which will spread in the air. So we're reducing those aerosolizing procedures. Some of our patients are getting proned, meaning that when they're having such difficulty breathing, they're being turned. There are all these prone teams that you might see in the news, which are physical therapists very often, and they're turning patients over onto their stomachs, which helps them with oxygenation. Some of these patients are deeply sedated, but I worked with a patient yesterday who just had her breathing tube removed. She was alert and speaking and eating, and she started to desat, so the oxygen in her blood was dropping a little bit. So she turned herself onto her stomach. So even though she's able to speak, this would still limit her communication abilities. She's not able to visualize her environment as well. She might not be able to access the call bell or reach for her phone or any of those really important things. So you've probably heard a lot about PPE in the news. There's a lot of attention to this, and we'll quickly go over what this means. This is my friend Michelle, a neuro NP, and she's wearing a face shield. And this is an N95 mask or gloves. This is called a PAPR, which is basically like a battery-operated hood that filters the air. And this is a gown. So we have to wear this for our patients with COVID-19, and even for patients who are PUI, which is a person under investigation, and they might not have a positive swab result yet, but we suspect that they have COVID and we need to protect ourselves and them just the same. There are so many communication barriers with PPE. It makes communication difficult for everyone, for provider to patient, even provider to provider. I often find myself not even recognizing staff in my own department when I see them with this PPE on and have to ask them to identify themselves. But the mask really compromises speech intelligibility. So your speech can sound muffled. And if you're in the room at the patient's bedside, there's all of this background noise in the room. There's alarms and there's beeps and then there's ventilation. And so if you are a patient, and we can all be patients, so this really applies for everyone, make sure you ask your provider to repeat any information, make sure you understand what's being shared with you. And as a provider, you can make sure that the patient has their glasses or their hearing aids on, use a lot of gestures, speak slowly, make sure the patient understands you. Masks also really limit facial expressions, which is kind of challenging because it takes away some of the empathy that we can show. And also for patients who are deaf or hard of hearing, we're taking away their ability to lip read. And even if you're not deaf or hard of hearing, we actually use those visual cues when we realize. And so we ask patients to try to find a way to connect with their peers. At NYU, I've noticed in the past few weeks that families are coming to the hospital and dropping off all sorts of pictures that they want us to hang in the patient's room, so we can remember that's a person and that's someone that there's a whole group of people at home who really love them and care about them, and just remember that this is not just a patient. And for providers, you know, your facial expressions may be limited, but I often tell patients, you might not see it, but I'm smiling under my mask, or just trying to get creative with verbalizing how you may be feeling with them. And PPE can look really scary. So as a patient, just be assured that this is for your protection and this is for everyone in the hospital. This is not anything specific to you. And as a provider, maybe make it fun. When I work with peds, we say, hey, I'm an alien for a day, or look at my astronaut costume, and just have a little fun with it. We really enjoyed seeing these pictures out on social media of people who are now taking their own pictures and attaching them to their gowns so you can see their faces. At Boston Children's, they're decorating their masks. These are healthcare workers who are not working with patients with COVID, but we have to wear masks wherever we go in the hospital, regardless of whether or not you have direct patient care. We have some tips that are on the patient-provider communication website, and I'll go over them very quickly right now, but make sure you get the patient's attention before you speak with them. Make sure also that it's culturally appropriate. So if you're making eye contact or you're touching them, know what the boundaries are for that. Speak slowly, loudly, try to establish a clear yes/no signal. And it really depends on what volitional movement the person has in their body and what they're able to do. Putting a sign up is very important because my yes/no signal may be very different from your yes/no signal. And also trying to train the nurse, they're so busy, but very quickly just say, hey, this person looks up for yes and closes their eyes really hard for no. And using visuals, you can't see it right now, but I am gesturing a whole lot, even though no one can see me. But writing key words down so they can understand you better, pointing to pictures or phrases on a communication board. This is an example of a communication board that you can use when a provider's taking vitals, and they can see kind of like a picture description of what's going on. The hospital looks really different right now. And on the left in this picture, you can see there's a lot of clutter, and it's kind of an organized chaos. Pre-pandemic, we would have nothing at all in the hallways. And now there's IV poles and computers and all of the PPE supplies. We have paper bags that are hanging because we are reusing our PPE. So we have to store them in a bag when we're not in a patient's room. And on the right, you can see outside of a patient's room, this is a glass door. It has all of the patient's information, and I've blocked out the patient's name. But what you can see is the patient's labs, their code status, their contact information. Unfortunately, if there is an emergency, if they need to call someone, there's a little sign that says white phone. And this is out there for the nurses to have a way to reach the patients. So they'll call the patients into the room, and it just shows that physical barrier that we're having between our patients and our staff. So we're spending less time in the room. I wouldn't say that it's less time total in the day, but we're making less trips into the room. And if you're a patient, you might want to write down a list and think of the things that you need or want. But if it's a much more urgent request, then use the call bell as needed. Provider, cluster your care, try to schedule activities of daily living, such as grooming, and always make sure, this is before the pandemic and definitely during and after, but always make sure that the patient is able to reach and access their call bell. You'll see a lot of extension tubing, so we're taking all of this equipment outside of the room and keeping it in the hallway. And so as a patient, you might wonder what IVs you're on, what drips you're on, and so it's really important to self-advocate and ask for updates. And a lot of rooms in the hospital now are negative pressure rooms, so there's a room before room, which just creates another barrier, another separation between the patients and the providers. And maybe you need to ask the nurse, as a patient, if you can have a good line of sight so you can see out into the hallway so you don't feel so isolated and secluded in your room. Maybe there's a way you can have hand signals so they can see you from the glass door if it's a glass door. And as a provider, you can just ask your patient, do you need anything before I leave? You know, can you see me when I'm out in the hallway? A lot of our nurses are using those computers out in the hallway right outside of the patient's room so they can see them from outside. Most hospitals now have a no visitors policy, and so we ask as a patient that you bring your own communication devices to the hospital, you download any apps, you make sure that your data plans and Wi-Fi are okay to use those apps. And as a provider, make sure that those patients are able to access their devices and their communication devices and their phones and their tablets and everything else. A lot of families want to FaceTime with their loved ones. So what I've been doing when I go see a patient, doesn't matter what I'm doing, I'll ask the patient right away, is it okay if I call your family and FaceTime? That might be the only time that they have a few minutes of being able to look at their family. Patients with special care needs, a lot of hospitals are allowing for pediatric patients to have one parent at the bedside. And also for patients who have communication needs at baseline, maybe you can have a caregiver at the bedside who's really familiar with your specific needs. So it's important as a provider to advocate for your patients when you feel that they really need someone at the bedside with them. And unfortunately, we do have to talk about end of life. Everyone should be doing this regardless of a pandemic, but making sure you have your advanced directives, designated primary healthcare proxy, and then an alternate. And as providers, just making our patients as comfortable as possible. My friend's husband passed away from the virus last month, and she was not able to be at his bedside. And so the doctor FaceTimed her when Joe was coding, and she was able to say goodbye to him and thank him, and she played their wedding song, and those were her final moments with him, and she wouldn't have had those if the doctor didn't think to FaceTime her. I'm going to quickly go over a case that I worked with a patient right when this was all starting to happen. He was in the hospital for a neurological condition. He was trach to vent, he couldn't speak. And his wife couldn't visit him any longer because of the hospital policy, and she was pregnant. She has since had the baby. He was using an alphabet board with partners scanning. And so I conducted the therapy session via FaceTime. I was able to train his wife on how to do partner-assisted scanning through the video. She was able to print the communication board at home, and in future times was able to use that with him. But he was able to pick out his baby name by doing the alphabet board. And it was really cool and kind of intimate to be part of that moment, but I was glad to help facilitate that. I want to turn things over to Rachel Santiago. She's at Boston Children's, as Sarah introduced us all before. And Rachel's just really amazing with creating resources and tools to prepare everyone for their communication needs. And she's going to go into how we can all be prepared.
Thank you, Tami. Wait to share my screen here. So I'm going to talk quickly about some of the changes to hospital services and inpatient virtual consults before we jump into this, how we can support communication planning. So as Tami mentioned, providers are actively trying to limit their time at the bedside, or at least limit the number of times they're getting up and going in. So most consults for COVID patients are virtual. Available services at the hospital may also be different depending on that hospital's policies and how staffing is looking like. So, you know, here at Boston Children's, a lot of our consult services are being done from home, from work from home, or from inside the hospital, but in the office. And so they're calling in via Zoom using a secure call-in that every patient room, as you can see on this patient's room, has their own call-in information, and that's how a lot of these consultations are happening. We also know that available tools that patients and providers can use to support these services is very different. So some hospitals are providing, you know, an iPad or a phone that patients can use to participate in these visits, but not every hospital has those kinds of resources. So it's really important to think about how patients can participate in communications with their consulting teams and with any kind of programming that's going on, especially if they use AAC themselves. So how are these hospital services looking different? Well, for one, rounds are happening outside of the room for many COVID patients. The person with COVID may only be getting face-to-face or direct patient care services from a single nurse, a single clinical assistant, and usually the attending physician, but perhaps one MD provider. Programming may be unavailable, or they may be happening through virtual technology. So here at Children's, we have maybe one day a week when our music therapy staff is here to provide for all patients, not just patients with COVID, but a lot of these services are happening from outside the room. So the entire hospital experience is really deviated for a lot of people. And even patients that are used to going into the hospital, maybe they've had multiple admissions, because of COVID, everything is looking really different. So what does this mean for people who use AAC? Well, for one, we really want to make sure that AAC consumers have a way to participate in virtual communication during a hospitalization. We know that a person's ability to access AAC when they're in the hospital for any reason might be different because of their medical condition or because of their recovery. And the same could be true for virtual communication access. So we really need to think about, you know, can virtual visit technology be integrated into an existing system, or can it be used in tandem to that system by the patient? Does another person have to assist in setting up a virtual visit, or can the patient do so independently? Do they need a second person like the nurse or caregiver to get them set up with their AAC system? Or are they going to have another caregiver at the bedside? And even though a lot of hospitals are lifting these visitor restrictions for people who need them because of a disability or a special care need, some of these caregivers are actually diagnosed with COVID themselves and therefore can't be at the bedside. So we still have to think about, preparing for communication and virtual consultation regardless. For time's sake, I'm not going to go into much detail here, but this was actually a patient that I was consulted on with autism who had COVID-19, and she was actually quite sick. She was intubated for about a week and deeply sedated, and she's a NovaChat user. So her nurse, Stephanie, who you see in these pictures here, was really remarkable at making sure that she was providing comprehensive care at the bedside. Our current policy right now is that I, as a consulting provider, do not go into COVID positive patient rooms, but rather I consult from outside the room using Zoom. So that's what we did, and we were able to actually set up mounting equipment outside the room, and Stephanie was able to bring it in and get her patient all hooked up and ready to go in case that she woke up needing to access her device. Regarding access, this is obviously a huge consideration for people who use AAC at baseline and people who don't. But this is also really important for people who are just hospitalized with COVID and need to be able to see their providers using, this virtual technology. The picture on the left there is actually a hospital iPad that our cardiac ICU mounted. So they provided their own equipment for mounting so that the patient and family could participate in their cares. The image on the right that you see is a setup that we did for a patient who thankfully just got discharged, no longer COVID positive. But because of his access needs, we also mounted the hospital iPad on the same mount so that he could visually access his providers as well. We really still need to keep feature matching in mind for all patients when we think about access. So thinking about what are those patients' unique needs and skills and matching that to what's available. So if, a lot of hospitals don't have the same kinds of resources, so we do need to be a little MacGyver, and hopefully everybody knows who that is, but for the young ones, thinking about how to get creative in terms of getting these kinds of setups. We also have to think about patient-specific needs, cultural perspectives and technology experience, religious beliefs. So, people who, for example, Orthodox Jews who may not use technology on the Sabbath, and kind of how are we going to support patients in that way. So thinking about communication planning and preparing for emergencies, we're going to talk about healthcare providers and community providers and also patients, because there's, any key stakeholders that have that are going to be interacting with patients, and the patients themselves can be doing something to prepare. And we know that early preparation is going to yield better outcomes. So thinking about how healthcare providers can prepare, we really need to be educated on how to promote communication enhancement. We need to learn about our hospital's policies, what's already in practice, what are the needs, what are the care gaps. We need to work within our scope of practice to support these needs. So as a speech pathologist, it is 100% within my scope of practice to provide communication support for my patients. We can easily print, laminate, and disseminate communication tools, maybe create some ready-made binders on ICUs and COVID units. We can train staff on how to support communication access. And this last checkpoint here, identifying a champion. If we can identify someone who's invested in bedside communication enhancement and patient-provider communication enhancement, that can really go a long way. So if you have a nurse or a child life specialist or a physician or a social worker who is still seeing COVID positive patients who can help promote this effort, it's going to be really, really helpful. Thinking about resources, Tami already brought up that we do have some free resources available on the patient-provider communication website. We have tools that we've prepared in English. A variety of different topic boards were created by our task force, which, by the way, consists of people who actively provide critical care support and have worked in acute care and participate in communication science research. We've also created these as PowerPoints so that they could be completely customized to a specific patient's needs or to a specific institution's needs. So please feel free to play around with them as indicated. And if you do, you can certainly share that with us because it just makes us really excited to know that people are using these tools. We have a variety of languages translated for all of these tools as well. We have a few more that are going to be created soon. A lot of international colleagues across the world have also submitted some tools. Other companies have created lots of translated materials. So there's really a lot out there, and it's definitely, as Jessica mentioned earlier, language difference is a huge reason to support bedside communication. We also have tips on material preparation. We've had a lot of hospitals create communication boards binders just to sort of store all of these materials in one location where frontline providers can access them. Some are creating little packets with one of each of the boards for patient rooms. If you don't have a laminator, which is sort of the go-to thought for a lot of people, you can back it onto a clipboard so you have a sturdy surface. You can put them in a protective sleeve. You know, really think about what resources are available to make sure that these can be utilized easily. Community providers, there's definitely a lot that community providers can do. First thing, they can reach out to hospital personnel, find out what's available at your local hospital, find out what you can do for your patients to be able to help them in the event of a hospitalization. Supporting patients in materials preparation, so backing things up to the cloud, page sets and other materials, creating medical care notifiers like medical passports and emergency cards. So providers have a way to learn about a patient, and this is really, really important for patients who won't be able to have visitors at the bedside or won't be able to have an informant with them. Making sure people can access virtual technologies and really access mobile technologies as well too. It's important for other facilities to also plan to support communication with families remotely, especially if patients get hospitalized. Due to the close proximity of patients and residents to one another at these residential facilities, social isolation is really significant and impactful right now. So it may be especially challenging for elderly patients if they get hospitalized, if they don't have experience with mobile technologies. So thinking about adaptations for certain populations is going to be really important. At testing sites, there's a lot of people going through drive-through testing sites and emergency departments to get tested. We also have a policy whereby every patient that's getting an operative procedure has to get tested for COVID. So lots of people getting tested every day. And if your patient has sensory integration issues or difficulty comprehending what's going to happen, using visuals and social stories can be extremely helpful. We also want to make sure our patients know their rights, know how they can advocate. They also can call local hospitals to find out what are the visitation policies, but what are the visitation policies for me as a person with a disability? What communication supports can be available to me? What can I bring? What am I allowed to have in my room? So really thinking about advocating, self-advocating for needs. These are just some example social stories that we've created at BCH. This is one that we actually keep in our ICUs in case a child is admitted with COVID and need some support and understanding, why they have to stay at the hospital overnight. We have some stories developed for our drive-through sites for testing. We have some materials that are great for provider to patient communication. So queuing, I think Tami talked about this a bit already, but queuing patients as to what's about to happen using more of a visual scene type hybrid topic board, if you will. There are a lot of medical passports and emergency card templates out on the internet. At BCH, we've created a really comprehensive passport that sort of is in line with some of our documentation needs. So it's really a great way to inform staff. I get really excited when patients come in with these kinds of things because it really helps me do my job. And it also helps me communicate with my patients if I know about how they communicate themselves, how they best understand people, what's their tolerance for medical procedures, and more. Go bags. These are really, really a really great thing to do ahead of time as well. I kind of equate it to being pregnant and having to pack a hospital bag, 2 months ahead of time if you're an overachiever. But in the event of an emergency, we're not thinking about, well, ooh, what can I pack in this go bag? So having even a list prepared or a packed bag prepared ahead of time with some essential items, including backup communication systems, is really, really important. Tami already talked a little bit about medical decision making and end of life directives and care. This is definitely not something that we want to have to think about. But it's really important to think ahead. In addition to just thinking about advanced directives, we want to be prepared as staff as well. So if a patient's awake and cognitively able to participate in these kinds of conversations, we really need to make every effort to include them and to let them be in control and have autonomy in the context of these decisions. On the patient provider communication website, we actually, I think yesterday, just posted a suite of communication tools related to medical decision making and serious illness. I think they're definitely worth a look. When using these kinds of materials and when engaging patients in these kinds of conversations, it's really important to also reach out to palliative care teams, chaplaincy programs, social workers, just to make sure that these conversations are facilitated in the best way. They are the experts on that kind of thing. So a few takeaways. Unfortunately, we're all at risk for COVID-19 and the potential communication challenges that come with it. If we can prepare ahead, it's really important to try. We know that early preparation and being proactive can yield some more positive experiences. This pandemic is evolving. I can't tell you how many policy changes there have been day to day, just in my practice. So we're really having to modify, we're really having to think on our toes and be creative. Any chance to train, educate, and disseminate as a provider, even as a patient and a caregiver, is really going to make an impact. And certainly barriers do exist. They will continue to exist, but solutions exist too. Advocate, I think from the patient perspective, advocate as much as you can for your own rights and access needs. And as providers, we're certainly getting a lot of, as SLPs, we're hearing a lot from other SLPs who are being told not to come in the hospital and not to be at the bedside. And so if we can advocate within our own roles and responsibilities, there's always something we can do to make a difference, whether it's working from the front line or working from the sidelines. Certainly think about what your role is in all of this. Before we take some questions, I know we're short on time. We just wanted to give a little bit of a shout out to the task force that we've been working with. A lot of work has gone into the creation of these materials that we've put up on the website. And it's really just come from a place of really compassionate individuals and really smart individuals. These people are amazing. So thank you to all of them. We are trying our best to disseminate information through a few different channels. So please check those out and keep revisiting the website. We're adding stuff all the time. And thank you.
Thank you all. There's a couple of questions that, but I'm going to start with a comment from someone who has a suggestion, which is this person has used clear packing tape to completely cover each side of a page or piece of paper when she didn't have a laminating machine.
Great idea.
Yeah,
That's a great idea. Yeah, for sure.
I actually use clear packing tape for all of my labels, for all of my equipment. So it's a great idea.
great. And another person, I don't think she's still on, but she asked about the use of electrolarynxes when somebody is, when somebody's really struggling with a trach.
Oh, I see. So not someone who's had a laryngectomy probably, but using that. That has generally not been part of my practice, just because if you've ever tried to use an electrolarynx, it's a really specialized skill. It takes a while to find that sweet spot on your neck or intraoral adapter to really figure it out with the resonance, and then how to articulate, when to push the button for voicing and when to leave it off. So it's not something that I've used, but I know other people do use it and find some success with it.
And what this person was describing was somebody who was not very, people who were really in coming out of delirium and maybe quite weak. So I hear if there's a lot of skill involved, maybe not.
Yeah, this is Rachel. We have an electrolarynx here, even in pediatrics, although most kids are pretty fearful of it because it's so noisy. But usually when people are trached and coming out of sedation, the weakness and the deconditioning that they experience, obviously delirium too, and being able to follow a sequence of demands would make that pretty challenging, but there may be like the right person for it, for sure.
Somebody's also asked, do you get enough time to use these materials with patients?
Asking as us personally, or just providers in general? So my job is just to do communication enhancement. I don't do any dysphagia or feeding work here. So I do, although certainly we're on a rotating schedule, so there's only one of us in-house at a time, so it's definitely made it challenging. But my answer is yes, we make time for it. Our frontline providers, like our nurses and physicians and other people, I have to say I'm really proud of them. They also have made the time for it. It's definitely person specific, but yeah, they're trained the right way.
And this is a related question. What's been the response from nurses and doctors who are taking care of the patients who have difficulty communicating?
I've had a really amazing response. We've been building a hospital culture for about 6 years now on patient-provider communication, so we had a little bit of groundwork. But now we're getting consults in for patients who are intubated, and the comment on the order will say for communication, which usually it says for swallowing when patient has the breathing tube out. So I think people are really just trying to do their best, and especially now when patients are so isolated and they don't have that contact with their families as much, or even the providers, people are really advocating for communication supports.
Yeah, just kind of to go off of that as well, I think it's really interesting the opportunity we have to have kind of like this mainstream technology available to patients. It's kind of opening up, I think, some of our nurses and our physicians' minds about how we can integrate that into communication interactions in the hospital. So they're finding new ways to kind of fit it into their individual contexts. So when the materials are available and they kind of have a little bit of support to see those spots that they can use it, they're taking those opportunities, which is wonderful to see.
That's great. I'm going to say one more question, but we're not going to have time to answer it because it's a really big question, but it comes from Brazil. And this person would like to know, do you have a specific board for each patient? And so when they're in the hospital, what happens with the communication boards. And I think that that's a question that we can take offline and maybe communicate further with this person. I think we're running out of time. So I'm going to say that if you have additional questions, please type them in now. And we will be trying to respond to them. And we can get your email, or it would be good to include your email so we know who to contact directly. And I just want to say not only thanks on behalf of everyone who's been on this webinar, but thanks on behalf of the world for the work that you all are doing. And several of the comments that have come through have just emphasized how amazing they think you all are. So thank you for sharing this very informative hour with us. And thank you all for participating and learning about what you can do for patients or for people, for family members who might be compromised in patient-provider communication at some point. For ASHA CEUs, we've already talked about how to access them. This is on the slide. And just one thing, you need to be aware that to submit this form, it has to be in by the 12th of May. And also, we'd like to invite you to the next webinar on May 5th with Catherine Dorney on aided language input. We would appreciate filling in the evaluation survey. That's very helpful, and remind you that the webinar will be archived as others are and available in a few days, and that you do have access as well to the slides, the great slides. So once again, I want to thank the three Wonder Women for this great presentation, and turn it over to Franklin. And thank you all for coming.
Thank you very much, Sarah. I want to, obviously, I want to thank very much Jessica, Rachel, and Tami for a great presentation, not only, but for being out there and being on the front lines. And I know I speak for everyone who was on tonight. Thank you guys very much. Thank you to the entire USAC team who supports these webinars. Isaac is thrilled to be able to make the platform available and work with our friends in the US and around the world. And as just a final point, I will remind everyone that Isaac 2020 has been postponed, but it will. We are making plans for a fabulous conference in 2021 in Cancun, Mexico. And please visit the Isaac website regularly, because even though our physical office here in Toronto may be closed, we are working very hard with all of our associated organizations, sponsors, and exhibitors to make a lot of online content available, including these types of webinars. So we'll look forward to seeing everyone at the next webinar, and stay tuned, and please stay safe, everyone. And please do listen to your local, regional, and national authorities on the ever-changing health and safety regulations. Good night. Thanks again to everyone. We'll see you soon.